بسم الله الرحمن الرحيم. أنا يسعدني أكون
يا مالك كنت تجيب لي ورقة ولا؟
بسم الله الرحمن الرحيم. شكرا دكتور هشام على المقدمة. يسعدني النهارده أكون مع الأستاذ الدكتور أحمد فريد ودكتور رشا. دكتور طلال لسه هيجي بعد شوية، وأنا إن شاء الله النهارده أتكلم على Renal Cell Carcinoma and Mimics in a case-based approach. نبتدي بالspecific growth pattern and consequent specific features for renal cell carcinoma and others. This is a well-defined expansile lesion which characterize most of renal cell carcinoma, and this is infiltrative type for other lesions. Here are the renal cell carcinoma with well-defined outline with enhancement after contrast administration in the nephrographic phase, and this is the excretory phase image with a washout of contrast, and still the outline can be seen. This pattern is displacing rather than infiltrating the renal parenchyma. The other pattern is the infiltrative pattern, which is the difference is that here there is poor interface between the mass and the renal parenchyma. Here there is a well-defined interface, here is poor interface, and also the reniform shape or more or less preserved of the kidney. Here there is usually expansion, particularly in exophytic lesions. So these are most of renal cell carcinoma, but some renal cell carcinoma can show this infiltrative pattern. An example for the infiltrative pattern here is coronal and axial post-contrast CT images. Here we can see ill-defined lesion in the medulla infiltrating the renal cortex, and this pattern proved to be a renal medullary carcinoma. Also here it is ill-defined mass with poor interface between the lesion and the renal parenchyma with renal vein and inferior vena cava thrombus. The presence of renal vein and cava thrombus are characteristic of renal cell carcinoma, but here it is also the infiltrative pattern. So some lesions like this renal cell carcinoma clear cell type can show this infiltrative pattern, particularly with sarcomatoid differentiation. So this is the differential diagnosis of renal masses according to the growth pattern. This is the infiltrative growth pattern. Some atypical renal cell carcinoma with its three types, clear cell, papillary, and chromophobe renal cell carcinoma can be atypical and show this pattern. Renal medullary tumors, medullary carcinoma, and collecting duct carcinoma, which is known as Bellini duct carcinoma. Renal pelvis tumor, urothelial cell carcinoma, and squamous cell carcinoma. Metastases, particularly from bronchogenic carcinoma, colorectal, gastric, and breast carcinomas, which are the common primaries with metastatic deposits in the kidney. And lymphoproliferative disease like renal lymphoma, leukemia, and plasmacytoma. And at the end of my talk, I will give the last differential diagnosis of this infiltrative pattern, which is mimickers of renal cell carcinoma. I start with this case, so I prefer to be interactive, but for the sake of time, I will ask, and some questions will be written, and I will answer the questions. And when I ask or see a question, just keep the answer in your mind, and then as a self-evaluation show you are correct or no. So this is a pre-contrast CT with enlargement of the left kidney compared to the normal kidney with enlargement of the renal vein. This is a post-contrast CT axial image, and here an axial image in portovenous phase. So I will ask about what these post-contrast phases and the T stage, N stage, and what is the pattern of hepatic enhancement, and are there other abnormalities? So for the phase, this is, as I said last time, this is a late arterial phase, which is called corticomedullary phase. Usually we can describe the phase according to the normal kidney. Here we can see the corticomedullary differentiation. There is loss of corticomedullary differentiation here on the affected side. The kidney is enlarged with abnormal vasculature here and abnormal vasculature in the inferior vena cava. So this mass is not well defined as the usual renal cell carcinoma, shows the infiltrative pattern with vena caval thrombus. This is also in the late arterial phase. We can see here enhancement at the wall of the inferior vena cava. And this is a coronal reformatted image to show this abnormal pattern of hepatic enhancement. This is hypo enhancement in this segment and normal enhancement at others. So this is a differential enhancement of the liver. We will discuss the cause now. And regarding here, the cause of hepatic enhancement here, the hepatic vein is, the drainage is impeded by this vena caval thrombus. This is a normal enhancement with the draining vein is not obstructed like this one. So this is according to the obstruction of the vena caval thrombus to the hepatic drainage. This differential enhancement is seen. So what about this lymph node? This is a lymph node in the coronal post-contrast image, and this is the upper margin of the kidney. So this lymph node is superior or above the upper margin of the kidney. And what about other features, other abnormalities? We can see here enhancement of this part. In the coronal image shows this is a left gonadal vein. So there is tumor extension also in the left ovarian vein here. This is the additional findings. And this lymph node, what is the staging of this lymph node? Because it is above the superior margin, it is considered extra-regional lymph node. So according to the last classification, N1 if there is any regional lymph node metastasis, and M1 if there is distant lymph node metastasis. So the last case can be categorized as metastatic lymph node because it is extra-regional lymph node. This is in the coronal image. What is about this case also for renal cell carcinoma? This is a renal mass here, and there is a retro-aortic left renal vein. The proximal part of the vein is invaded. The distal part is patent. So also there is a regional lymph node enhancement, regional lymph node metastasis here, and hepatic metastasis. So it is a T3A due to the extension into the left renal vein. N1 due to the regional lymph node enhancement, metastatic due to the hepatic enhancement. So if I ask if there is no hepatic or other distant metastasis, no hepatic metastasis, what is the stage of this case? Some can say it will be T3A also, N1, M0. But in this situation, without the hepatic metastasis, it will be also metastatic. It will be M1 because we have here the arrow pointed to extra-regional lymph node at the celiac area. So here, the upper margin of the kidney, these lymph nodes above. So in coronal image, any node above or below toward the iliac vessels, so below to the lower margin, it is extra-regional lymph node. So it is metastatic lymph node. So this is in coronal image. What about the axial image to differentiate regional from extra-regional lymph node. This case has a right renal cell carcinoma. It's not seen in this image. With regional lymph node here, it's the white box. Any lymph node here to the same side of the midline, it is regional lymph node. But here there is left para-aortic lymph node. So this lymph node in the black box here, it is extra-regional lymph node. So it is a metastatic lymph node staged as M1. To other cases for staging of renal cell carcinoma, because to avoid overstaging of renal cell carcinoma as renal cell carcinoma infiltrating the perinephric fat, to diagnose T3A due to infiltration of the perinephric fat, we have to see this irregular extension of the tumor to the perinephric fat, and here the regional line of the renal capsule. So there is, if it is confined to this line, it is T1 or T2 according to the size. If there is this irregular extension here beyond the confined of the kidney, so it is extension beyond the renal capsule, it is a T3A tumor. What about the vascular invasion? This is axial and coronal oblique post-contrast CT images. This is invasion of the renal vein. The IVC, is it invaded or not? It is not clear on CT. So on MRI, post-contrast, we can see the renal vein invaded, but no extension into the vena cava. So previously, MRI was superior to CT for venous tumor extension, but currently this images with 4 multi-detector rows with the advancement of the CT technology. The results now are comparable between CT and MRI in evaluation of tumor venous extension. So it is T3A due to renal vein, but if the vena cava is invaded, it will be T3B. This is an example of tumor extending into the renal vein on post-contrast MRI image. Here is the coronal image, the tumor extension. This is the upper margin of the tumor below the intrahepatic portion of the IVC. So what is the T stage of this tumor? It is T3B due to invasion here, and it is invades the subdiaphragmatic portion of the vena cava. And this is a late excretory phase image with this lesion, this tumor in the left kidney. The left kidney show no excretion of contrast, probably due to clot obstruction. And this is a filling defect here. Is it a second tumor, or usually it is due to a filling defect? If we see the early image, it is not non-enhancing, and it is a filling defect due to blood clot rather than a urothelial tumor. What about the T stage of this tumor? Malignant right renal mass with vena caval, significant vascularity here in the vena caval tumor thrombus. And you can see here some vessels in the wall of the inferior vena cava. So what is the stage? Many answer I received before for this case was T3B, because it invades the subdiaphragmatic portion of the IVC with no supradiaphragmatic invasion of the atrium here is free. But this stage is T3C. Why T3C? Because it is fixed to the wall. So even if it is in any level of the vena cava, if it is fixed to the wall as evidenced by this vascularity in the vena caval wall, it is T3C. What about this tumor, and what is the stage of such a lesion? Here we can see on CT a lesion here with hypodense areas and vena caval thrombus with hypodense areas. These areas here on MR fat suppressed image show a drop of signals. So it is a fat content here and in the tumor thrombus. So it is an angiomyolipoma. The angiomyolipoma with abundant amount of fat can extend to the vena cava like the renal cell carcinoma, and also can extend into the perinephric fat. This is a typical angiography of the angiomyolipoma with microaneurysm on renal angiography, and also can see the defect of the renal vein and caval thrombus. This is a non-contrast CT with this exophytic lesion from small-sized left kidney. This is a normal right kidney, and in the corticomedullary phase, and there is significant enhancement of the lesion, and more than the cortex of the kidney. In the nephrographic phase, there is some washout of contrast as measured as we measure the attenuation value here, and in the delayed excretory phase, there is significant washout. So, what are the tumor characteristic of this lesion? Which tumor shows this tumor characteristic or enhancement characteristic? These are the clear cell renal cell carcinoma, significant or avid post-contrast enhancement in the early phase and significant washout thereafter. What about the pattern of enhancement of this tumor? It's pre-contrast exophytic large lesion here in the corticomedullary and nephrographic phase show minimal enhancement, significantly less than the renal parenchyma, and no significant washout at the delayed excretory phase. So this mild enhancement with prolonged or persistent pattern, no washout, are characteristic of papillary cell renal cell carcinoma. This is an anterior cortex renal mass with chemical shift MR imaging. Here is the in-phase image, and here is the out-of-phase image. We can see on the opposed phase image significant drop of signals of the mass. So what are your diagnosis of such a mass? Also, many answers were that it is angiomyolipoma, but it is a wrong answer, because angiomyolipoma does not show the drop of signal on the out-of-phase image, because the chemical shift image shows that the lesion contains intracellular lipid. But in angiomyolipoma, this is fat cells or macroscopic fat, not intracellular lipid. So this is the drop of signal is characteristic of clear cell renal cell carcinoma. And this is an angiomyolipoma, hyper intense on T1 without fat saturation, and this T1 with fat set, we can see a significant drop of signal due to this fat cells. So angiomyolipoma, to diagnose angiomyolipoma, we have to have a fat suppression technique, not a chemical shift imaging. So some about the images about multiparametric MRI of renal masses. This T2 axial image show a mass here well-defined, with well-defined interface between the lesion and the parenchyma. It is relatively hyper intense than the renal parenchyma on T2. This is characteristic and show avid enhancement. And in the diffusion weighted image show restricted diffusion and low ADC. And on chemical shift imaging, it show minimal drop of signals in the out-of-phase image due to the intracellular lipid. So these are the characteristics of clear cell renal cell carcinoma. This is another mass. It is hypo-intense on T2, hypo-intense. And on chemical shift imaging, this is the out of phase image, and this is the in phase. So characteristically, it shows drop of signal in the in phase image due to the hemosiderin content of the lesion. And this is the post-contrast corticomedullary phase, minimal enhancement, also in the no washout with in the nephrographic phase. So these are characteristic of papillary cell renal cell carcinoma. What about this mass? It shows significantly hypo-intense pattern in the and avid enhancement after contrast administration, and no significant change in phase and out of phase images. These are characteristic of low fat containing angiomyolipoma. Show both lesion, this low fat containing angiomyolipoma and the previous lesion papillary renal cell carcinoma shows low attenuation or hypo intense signal in T2. However, this show marked enhancement due to the vascular content in the angiomyolipoma, and the papillary cell show minimal enhancement. This is how to differentiate between low fat containing angiomyolipoma and papillary cell renal cell carcinoma. Also, the angiomyolipoma, this is a case of low fat containing angiomyolipoma because it is a soft tumor. So it shows a characteristic shape. It's like the ice cream cone because it arises from here, a pedicle from the kidney, and go grows outside the renal outline. This table summarizes the MR features on multiparametric MRI of solid renal mass, clear cell renal cell carcinoma, high signal on T2, and due to microscopic fat, it shows drop of signal in around 30% of cases in out of phase image, and due to hypervascularity, it shows avid enhancement. Papillary cell, low signal on T2, hypovascular show minimal enhancement and may contain hemosiderin, so it shows a drop of signal in the in phase image. There is no specific imaging feature of chromophobe and oncocytoma. It needs further evaluation. Oncocytoma and chromophobe renal cell carcinoma has similar imaging features. The classic angiomyolipoma have a macroscopic fat, show drop of signals on T1 weighted fat saturated image, and the lipid poor angiomyolipoma low signal on T2 like the papillary cell, and show may contain microscopic fat, but it shows avid early enhancement compared to the papillary. This is just one image to have your suggestion about this patient with hematuria. This is a post-contrast image on coronal MR image, and here we can see a large renal cyst, a small renal cyst. And in your opinion, what is the cause of such hematuria? It is due to pelvic calcification tumor, as evidenced here by enhancement of the this soft tissue lesion occupying the pelvic calcification system, because it is a T1 weighted image. So this size of the pelvic calcification system, if it is fluid, it should be black like the simple cyst, but here it enhanced. And also, like what we summarized at the beginning of the infiltrative type, this is a central renal mass with ill-defined interface between it and the parenchyma, and it in case and it obstruct or invades the renal sinus fat and the renal parenchyma posteriorly here. So this is a case of renal pelvic tumor, or what is called urothelial cell carcinoma. This is a male patient, 55-year-old, presented with dyspnea and subjected to this chest X-ray. It shows elevated right diaphragmatic copula, and abdominal ultrasound show large mass at this area, the upper abdomen on the right side, heterogeneous mass of heterogeneous echogenicity on CT. You can see this large mass on non-contrast CT. It's enhanced heterogeneity. It shows non-uniform enhancement with displacement of the some organs, and here the coronal post-contrast image. Can you determine the anatomical origin of such mass, liver, kidney, or suprarenal? From this image, I can say that it is not renal because the kidney is displaced and the outline is preserved, and due to lack of peak sign. So it is either from the suprarenal or the liver. Here, the displacement of the vena cava anteriorly and medially, it goes with the suprarenal rather than hepatic mass. So I think it is a large suprarenal mass. And what's the diagnosis of such mass? I think it is cortical carcinoma. Adrenal cortical carcinoma, and this is a differential diagnosis of large solid adrenal mass, adrenocortical carcinoma as this case, and this is the other differential diagnosis: pheochromocytoma, metastasis, myelolipoma, hematoma, hemangioma, and neuroblastoma or ganglioneuroma. And in such large masses with ill-defined origin, this is an indication of diagnostic angiography. Nowadays, there is almost 2 indications to have angiography, renal angiography for just diagnosis, for no intervention. In this case, with large mass between the liver, upper bowl of the right kidney, and suprarenal, to know the origin by the vascular specificity. Here's the inferior suprarenal artery arising from the first part of the renal artery, supplying the mass, and to confirm, we have to categorize the middle suprarenal artery, which arises from the aorta. Here, the mass is significantly supplied by this middle suprarenal artery. So it is a suprarenal mass. And the other indication for selective renal angiography as a diagnostic tool is to make it preoperatively for possibility of nephron-sparing surgery or partial nephrectomy for such mid-zonal mass, because the mid-zonal mass is difficult to be treated by partial nephrectomy. This is a patient has a previous radical nephrectomy for left renal carcinoma, so it is a solitary kidney, and the angiography gives a better vascular map before surgery, particularly if the CT angiography or MR angiography is equivocal. This is a female patient with pain, malaise, and loss of weight, and this contrast-enhanced CT was performed. This is in the arterial phase image, and we see this is the kidney, and here this hyper-intense structure in the arterial phase is either stones or calcification if the density is near that of the bone, and it could be vascular if it is near the density of the vessels. But here the aneurysm is excluded, as it is no direct relation to the vessel, and it is more dense than the vascular structure. So it should be stones. And this pattern of the kidney in the nephrographic phase, it shows minimal enhancement compared to the normal kidney, and this is an evidence of horseshoe kidney. And this is the stones with minimal enhancement of the kidney, and in the excretory phase, no excretion of contrast by this mass or by this kidney, and with the stone here, normal excretion on the right side. And we can notice also this significant perinephric reaction here surrounding the kidney with thickening of the facial planes here in the early phase, also in the excretory phase image. So the diagnosis of such a case is xanthogranulomatous pyelonephritis in left compartment of a horseshoe kidney. Horseshoe kidney, as you know, is a chronic granulomatous disease and mostly occur in association with renal pelvic calculus. This is a typical type of xantho with large mass at the renal pelvis. But there is also some less common type, which is non-calcular type, which usually focal xanthogranulomatous, not affecting the entire kidney. So it may mimic neoplasm. Either this is the classic calcular type affecting the entire kidney. This type is easier to differentiate from tumor, but the focal involvement mostly due to focal obstruction is difficult to differentiate from tumor. This is an example of the classic type with a stone and multiple cavities and with reaction surrounding the kidney. This is the classic xantho, but this focal xantho proved post-operatively with this soft tissue area. It may mimic a malignant cystic tumor of the kidney invading the psoas muscle. What about this nephrographic phase image and the delayed phase image? This is a mass hypo-attenuated or mass of low attenuation with some hypodensities suggesting cystic degeneration here. Wash out on the delayed excretory phase, but with persistent contrast here surrounding the lesion. It could be a tumor with cystic degeneration, or if there is in the history, because the history is very important to have appropriate history and the clinical data like history of fever, pain, leukocytosis and so. So this is a case of focal nephritis, not a tumor. And on CT, focal nephritis is characterized by in the delayed scans, maybe 1, 2, or even 3 hours after contrast administration, dense inhomogeneous staining of previously low attenuated area. This may be surrounding the tumor or maybe some far away from the tumor due to obstruction of the tubules by the debris and pus cells. So this impedes the washout of contrast. So this staining around the tumor or the mass never occurs in renal cell carcinoma. As the abscess is more easy to differentiate. This is a renal abscess on MRI. It shows hyper intense on T2, low on T1 on here, and with contrast it shows marginal enhancement of the sequel lesion. This is a plain film showing this large mass on the left side with air inside the air molecule. So it is a characteristic of emphysematous pyelonephritis, and emphysematous pyelonephritis is easy to differentiate from any neoplastic lesion due to the gas within the lesion. So it's called emphysematous pyelonephritis if it is intraparenchymal gas, and if the gas is in the pelvic cell system only, it's called emphysematous pyelitis. Emphysematous perinephritis is called when the gas is in the perinephric space. It's called the perinephritis. What about this case? 38-year-old male with bilateral loin pain and skin lesions. Here we can see in post-contrast images these multiple bilateral renal masses. Most of these masses have this central stellate-shaped scar. So post-operatively, these masses are proved to be oncocytomas. So oncocytoma, multiple oncocytomas, particularly bilateral oncocytomas in patients with skin lesions are characteristic. We have to do all, before the final diagnosis, CT chest. There is some cystic lesion on the CT chest. So this cystic change with the skin lesion and bilateral multiple oncocytoma occurs in a kind of, or one of type of the hereditary syndrome. It is Berthe-Hug-Dobby syndrome. This ultrasound shows this isoechoic lesion occurring into or extending into the renal sinus echoes. It usually misdiagnosed as central renal mass, but the echogenicity here is similar to that of the renal parenchyma. And on post-contrast CT, it has a similar enhancement pattern. And also in MR, it shows the different signal intensity, the same signal intensity in pre and post MR sequences. So it's the same as the renal cortex and the renal medulla. So it is a pseudotumor. It is called the hypertrophied columns of Burton. This type of pseudotumor is called invaginated cortical tissue or cortical infolding, part of the cortex infold into the renal sinus. And usually it occurs on the mid zone of the kidney and on the left side more than the right side. So to summarize, these are the cases which are presented for mimics of renal cell carcinoma, inflammatory lesions, xanthogranulomatous pyelonephritis, and focal nephritis, pseudotumors like hypertrophied columns of Burton, and also there is a second pseudotumor which is junctional parenchymal defect with renal hilar lip, and some benign tumor like angiomyolipoma, and in particular low-fat containing angiomyolipoma and oncocytoma. These are benign tumors, and also renal infarcts and immunoglobulin G4 related kidney disease, also recently described, that may be diagnosed as renal tumor. What about calcification in the kidney? To have such cystic lesion with calcification posteriorly here and inferiorly in the coronal pre-contrast image. After contrast and administration, this lesion show no enhancement in the early phase to exclude a cystic neoplasm with large calcification. So the tumor is excluded, and in the excretory delayed phase image, it shows filling of contrast in this lesion. So contrast is the lesion is connected to the lower calyx, evidenced by filling of contrast. So it is either calyceal diverticulum with this fluid calcification level due to secondary stones in the diverticulum, or TB cavity. But TB cavity show the calyces here are within normal, so it is no erosion of the calyces. So it is a case of calyceal diverticulum. For this plain film, it is large calcification of the kidney and calcification of the ureter. On another case with large calcification casting the whole kidney on CT, plain film and CT. So this characteristic of renal and urethral calcification of tuberculosis. On CT, sometimes on TB, we can see this lobar calcification here, and another case was large calcification in pre-contrast CT. So it is called butty kidney, or due to lobar calcification of tuberculosis. Just to mention that the calcification of TB is have features. It's not like that of the bilharziasis. In bilharziasis, the calcification is usually in the bladder and the ureter, and in the TB in the kidney and upper ureter. This is bilharzal calcification of the lower and middle ureter, and here also calcification in the bladder and seminal vesicle, and this is calcified seminal vesicle and calcified vas deferens. So this is a TB calcification which never occurs up in the kidney like tuberculosis. Last example of this mass with in a patient with a history of left nephrectomy for renal cell carcinoma, so with some bony erosion here. So to diagnose is it a recurrent renal cell carcinoma or not, we can do a CT guided biopsy. So what about the indications of renal mass biopsy to differentiate renal cell carcinoma from these other lesions? I will establish the indications are to differentiate renal cell carcinoma from metastasis in patient with extra-renal malignancy, like patient with bronchogenic carcinoma presented with renal mass. So to show this mass, is it a primary renal cell carcinoma or metastatic deposit from the well-known bronchogenic carcinoma? The second indication is to confirm the diagnosis of unresectable malignant tumor, like child patient with irresectable nephroblastoma. So we have to have pathologic diagnosis before receiving chemotherapy, and to diagnose suspicious mass in patients who are poor surgical candidates before the risk of surgery with suspected tumor. We have to do a biopsy, needle biopsy. And the last established indication is to confirm suspected inflammatory mass from renal cell carcinoma as cases with Zansu or cases with chronic pyelonephritis. There is also another indication like this case to differentiate lymphoma, metastasis, or multiple bilateral renal masses, like this patient with large mass on the right kidney with no cystic degeneration, and this is enhanced little than the renal parenchyma. So it is a characteristic of lymphoma, renal lymphoma. So the emerging indication are to for this multiple renal masses to differentiate lymphoma, oncocytosis, papillary renal cell carcinoma, and the metastasis. And the other emerging indication is for Bosniak calcification to have the biopsy from the soft tissue or the 670 to differentiate category 2F from category 3 Bosniak calcification. And now in advance of radiofrequency ablation, it is recommended to do biopsy. And the last one is the small, less than 3 centimeter hyperdense on CT and homogeneously enhancing mass, because about 25% of this mass is proved to be a benign lesion. So this is the indications, emerging indications. And thank you very much for your attention.